Okay, thank you very much for the kind introduction and for the invitation to the beautiful country of Mexico. Can I have my first slide? I'm honored to be allowed to give the EAU lecture here in Mexico. So I have some slides about the EAU. You, without any doubt, know, of course, the European Association of Urology. We are based currently, the headquarters is in the Netherlands. We have a lot of urologists, scientists, residents, and nurses as members of the EAU. They're coming from over 130 countries all over the world, not only Europe, of course. We have more than 14,000 EAU members, again coming from all over the world. And we do provide all kinds of output, publications, just as what I'm sharing, the EAU guidelines. It's a big book, of course it's also available online, and it's translated into more than 30 languages, so I think it has a lot of impact. And of course we have European Urology, current impact factor is above 10. It's a large journal with a lot of scientific information. We have European Urology Today, which is issued 4 times a year, 5 times a year, with all kinds of practical information and scientific information. And we also do something for patients. We have our EAU patient information, which again is translated into several languages. With regard to research, we have the European Urology Research Foundation, which has currently 6 projects which are ongoing to bladder cancer, and there are 2 in the pipeline. And we do a lot of online education. You see that it is going on year by year. We have some online courses, around 6, with a lot of participants. For the residents, we have the European Urology Residents Educational Program. It's a large meeting once a year, and we try to do as much as possible, of course, for our residents, because they are the future of urology. And then I'm also a member of the European Urology Scholarship Program, and we provide scholarships for more than 40 residents per year, just to go somewhere in Europe to learn additional skills. And finally, of course, we have our yearly big meeting. We just had a meeting in Madrid, and although everybody thought that would be nice weather, it was dramatically raining and cold, which is good for the Congress, but not for the social events. And that Congress in Madrid covered this year more than 1,100 participants, and more than 125 countries. It's a 5-day congress with a lot of abstracts, a lot of sessions, live streams, and webcasts. And I hope that we can all welcome you to the beautiful city of Munich next year. Here still says Madrid, but you know that next year's meeting in 2016 will be in Munich. Last but not least, I'm not doing that to be honest. I'm not really into all kinds of electrical things, but you can also join us at Facebook or on Twitter. Having said that, and actually going on with things that Professor Soloway told you about all kinds of basic things on non-muscle-invasive bladder cancer, I will proceed with intravesical therapy in non-muscle-invasive bladder cancer. I do have a lot of conflicts of interest, but I don't use them in my lectures, so that should be a major problem. As already indicated, we do use the risk groups for defined treatment in non-muscle invasive bladder cancer. We used to have a bladder calculator, but now we have 3 specific risk groups within our EAU guideline. We have the low risk groups, primary tumors, solitary, TA low grade and small, of course not CIS. You have your high grade tumors, which is or T1, or high grade, or CIS. And then a very exceptional group of multiple and recurrent and large tumors. And the major group actually is the rest, that is the intermediate risk group. And we are back to what we had in the 90s, and we are now again quite similar to the risk classification used by the AUA based on index 2, 3, and 4. You can see that they are quite similar. Then we have an additional, Professor Soloway also talked about that. You have your very bad cases, the high which is T1, G3 plus carcinoma in situ, multiple large G1, T1, G3 patients, T1, G3 plus CIS in prostatic urethra, very bad case, or for example, different histologies, micro-papillary tumors. Of course, you would like to subclassify some of those patients. For example, if you look at the intermediate risk group, it is a large group, and some are not very high risk, so it's the lower part of intermediate, and some are at the higher end of intermediate. Together with the IBCG, International Bladder Cancer Group, we found 4 factors that can differentiate between higher and lower risk in this intermediate risk group, and that's the number of tumors, tumor size, timing of the recurrence, and the frequency of recurrence. And I will show you in a few minutes what we can do with that with regard to therapy. Also, high-risk patients are not all the same. And just like Professor Solvay told you, I think the major factor for the high-risk patients is, as you can see here, the invasion of the tumor in the submucosa. If you have a very small invasion, that is totally different from deep invasion, as we call that T1B or T1C. And you can see in this recent large analysis that the T1 subclassification by far is the most important risk factor to subclassify these patients. And then you have lymphovascular invasion, carcinoma in situ, patients that do not go for BCG, size, and age. What is my practical translation? What do I teach my residents? I think that very high-risk patients are those with a large T1 tumor, so please do who you are. Concomitant carcinoma in situ, especially in prostatic urethra. Older patients do worse, women do worse, and obese patients do worse. And I use these factors to already decide on cystectomy in PT1 patients. What are the guideline recommendations for therapy? If you have a low-risk tumor, we discussed that already, during the cases you should give one immediate post-operative instillation. Do that on the day of surgery. You can use either drug, mitomycin, diabetic, or epirubicin, but make sure that there is not a bladder perforation. This is a guy that I treated last year. He had one small tumor, one resection, one instillation. Apparently he did have a perforation which was not seen during the resection, and he ended up with a fistula that did not heal and a shrunken bladder. So I had to do a cystectomy because of one installation that went wrong. So make sure to check it. The single cause of installation is not always known, and sometimes there are reasons for that. Here you see, for example, that on average in the US and in Europe currently less than half of the patients that should have an installation, here it is between 25 to 50, here 1/3, Europe 45%. So let's say 1/3 to half of those patients get one installation. And sometimes there are reasons not to do so. This study specifically looked at why patients did not have an installation, and 85% of the arguments were defendable. For example, if you're afraid of perforation, or if you think that it's more than a small tumor. So no, it's not always given, and yes, sometimes that is defendable. What is the ideal patient for one installation? Not all patients. I don't give that to intermediate or high-risk patients. Here you see a study from Scandinavia where they actually found that there is a small difference after one installation, but that's only for small tumors. If the tumor is larger than 5 millimeters, one installation is of no use. Same another study, also from Scandinavia, again showing that yes, there is a difference, but that's only for the lower risk group, not for the higher risk group. So only primary, small, solitary tumors respond to one installation therapy. And this is presented at the EAU a few weeks ago by Richard Sylvester. He did again a systemic review, looked at more than 2,000 patients, and he also concluded that yes, one installation is useful, course it doesn't do anything on progression or bladder cancer death. So yes, single post-op instillation reduces recurrence rate, but not in patients at high risk of recurrence. Immediate instillation, so is not more evidence, but only in the real low-risk patients. Intermediate risk patients, definition is difficult as the rest. And the treatment recommendation is mainly one instillation. I don't do that. And then additionally, chemotherapy for 1 year or BCG for 1 year. BCG is more effective, but also a little bit more toxic. And here you could use, to sub-stratify between chemotherapy and BCG, you could use this manuscript and you could use those factors that I just described. If you have no factors in the intermediate risk group, you're very safe giving chemotherapy. And you already see that if you have a lot of factors in the intermediate risk group, probably the best thing to do is to give intravesical BCG. So now we are almost at the point where we can subdivide the patients into good ones and the bad ones. High risk recommendation, very clear, is BCG, at least 1 year, up to 3 years of treatment. Also, unfortunately, in intermediate and high-risk patients, this is not done regularly. Here you see a recent survey that we did, and again you see that actually 50% or less of intermediate and high-risk patients get guideline treatment. And that's a shame, because that's of course not good for the patient. If you would not give one instillation in a low-risk patient, I think no harm done. In these patients, you really can harm them if you do not treat them properly. The highest risk group, very bad patients, you should already, at presentation, think about primary cystectomy. There is a worldwide BCG shortage. There is a problem in the US, there is a problem in Europe, so that might be something to consider. What about intermediate risk patients? For me, the first choice usually is chemotherapy. So then BCG shortage is not a real major issue. However, for high-risk patients, the advice everywhere, every guideline is full dose BCG for at least 1 year. And now, BCG shortage is a major issue. This is a very recent large trial from Europe, where you can see what the difference is between 1 year of treatment, 3 years of treatment, full dose, and 1/3 dose. And actually the only real difference you see between the lowest schedule, which is 1 year, 1/3 dose, and the highest schedule, which is 3 years, full dose. So that means if you treat less, you will only have more recurrences, but not more progression and not more cancer-specific death. So options to save BCG is indeed to give 1 year of maintenance instead of 3, again more recurrences, but not more progression. CIS preferably 3 years, and in the maintenance schedule you could consider giving 2 instead of 3 treatments, and you can do that with 1/3 dose instead of a full dose. All some of the options to save BCG. If there is no BCG, options are mitomycin C, gemcitabine, thermal chemotherapy, or of course cystectomy, and I will talk about that a little bit later. What about BCG failures? Failures is a very difficult definition. And of course, if you have invasive tumor and you follow up, that's failure. But also BCG refractory sometimes is a very difficult definition. What are the options? The guidelines in BCG failures are clear. You should consider immediate cystectomy. Of course, that has a very good survival. We already heard that quality of life after cystectomy definitely is not too bad, but of course it's also over-treatment in a significant percentage of patients, and even in experience that there is morbidity a lot, and there is mortality. And also cosmesis. You will have a stoma, or you will have a big scar. What are the alternatives? If you look at the European guideline, 2 things are mentioned. gemcitabine, or the combination of mitomycin C and hyperthermia. Beware, experience is limited and it is considered oncologically inferior to cystectomy. This is a recent review on the use of gemcitabine, and you see that it is superior to BCG in BCG refractory patients, so that might be an option. If you use that, you use 2 grams in 50 ml, but it is locally quite toxic. So yes, it is an alternative, but it has major local side effects. Immunotherapy, which is the North American standard, which is BCG plus interferon, of course that is an option, but realize that it is only based on one large phase 2 study. So I'm sure we would have to have more information to say something more about this. What about device-assisted installations? We are working with thermal chemotherapy already for 15 years. This is a study on BCG refractory CIS. Patients that actually were on the list for cystectomy, and you see that it doesn't work. Everybody, what we have spare cystectomy in approximately half of those patients in the first 2 years. And the same goes for our whole experience that we have now in our center. It is almost 200 patients, and again you see that you spare a cystectomy in approximately half of those patients in 2 years. So again, you are not able to treat everybody, but it certainly is an alternative. Take-home messages. Use the risk groups for different therapies in non-muscle invasive bladder cancer. And remember additional factors, subclassification, especially in high-risk patients. You can consider for example, the EU risk calculator for an individual patient, but it has some limitations. Initial therapy, I cannot stress that enough, is a good TOR with maybe a BTOR. You cannot compensate a bad TOR with chemotherapy or BCG. Additional therapy, single post installation is effective, it is safe and enough in the low-risk patients. It's not always done, it's not always feasible. In intermediate-risk patients, use chemotherapy or BCG and maybe try to subclassify this larger group of patients. In high-risk patients or patients with CIS, use full dose of BCG maintenance unless there is of course a BCG shortage, and in the highest risk group, consider primary cystectomy. What to do in case of BCG shortage is a predominant problem in high-risk patients. There are some safe alternatives with a lesser dose and a lower schedule, and if there is no BCG, consider mitomycin or gemcitabine or hyperthermia, or as a last resort, a cystectomy. And finally, standard therapy for real BCG failures is of course radical cystectomy. Alternatives might be gemcitabine, thermotherapy, and maybe interferon. But results should be treated with care.